Well, good afternoon, ladies and gentlemen. It's a pleasure to be here. It's actually my first time at this meeting, and I'll make sure down the road that I bring my team over. And I'd like to thank Dr. Katz for putting everything together. I think the team approach is obviously the only way to go. So we've been playing around or toying around with this device for a little while. This is a picture actually on the left of the first patient that was done in January 2011. And this was part of the initial clinical experience where we actually did a report. We had a survey of the surgeons, the OR nurses, and the ICU nurses to see whether they would like the device and if they saw any problems with it. And obviously it was very positive. You can read about it. It was published in Innovations. So we've published a few case reports, and now we're moving on to bigger papers. I have actually published a case report of a tamponade being relieved after milking and stripping with a lot of difficulties. And this is a case report that just came out in 2016 in the Annals, where we had the active clearance tube in, and we have on the left a patient that had a small effusion close to the right atria, and by actuating the system a little bit more vigorously than usual, we managed to pop out the clot and spare a take back, and I could go on with my evening. So post-op AFib, you all know, remains a big problem. 30 to 50% of patients will develop it. We say about 25% for CABG alone, but if you do a double valve with aortic stuff, it's probably closer to 50%. It obviously has an incidence on stroke and death, length of stay and cost, we've seen it. And obviously, not everybody has the same trigger, and perhaps that we won't ever be able to bring it down to zero, but definitely there is an individual susceptibility. Retained blood, as you've seen, and I'll try to explain, is an important, a powerful trigger for new onset post-op AFib. And it's oddly one of the most common complications of cardiac surgery, and currently there are no reliable preventative measures to get rid of it. So there's a history of failures. Most of you, depending how old you are, have seen these come and go. The pharmacological approach to preventing AFib. At our center, we've used sotalol in the past, amiodarone, N-acetylcysteine. None have been successful. Two have been. These are systemic steroids and posterior pericardiotomy, but none of them, I believe, are used on a regular basis in North America. Post-op AFib, I mean, a persistent problem. If you pull out this paper looking at 72 studies, more than 55,000 patients going back all the way to 1975, you can see that nothing has lowered the incidence of post-op AFib. And in fact, if we think that our patients are older with more comorbidity, the incidence actually may be going up. What's interesting, if you look at the time course of development of post-op AFib, it actually follows the peak in inflammation. You can see on the bottom line, the dotted line is AFib after non-cardiac surgery. Some susceptible patients will develop. But if you look at the peak of AFib, which is around day 2 or 3, this parallels the rise in CRP in the plasma of these patients. So basically, post-op AFib definitely has an inflammatory component.
Pardon me, I just want to, first of all, thank you for being here and presenting this to us, because it's important information, and appreciate the company's support in helping our meeting. I know it's great support for the meeting. But, you know, I have a special feeling for this situation, because over time, from time to time, new innovative technology occurs, which really can make a difference. And when I understood what this technology meant, and having stripped chest tubes in the past, and having, you know, gone through the whole thing with Fogarty catheters and the whole thing, understanding the issue of retained blood and when is the patient tamponading and the effects on multiple areas, when I became aware of this technology, I thought this is truly innovative, and this is a unique system. So I just wanted to say that to have them here at this meeting and to talk about it, I think is very important. As you know, it's very difficult to go into a hospital these days with the Sunshine Act and people to talk about this. But it's very important information, and I think as we go forward as a specialty, I think it'll become appreciated. This is unique technology. So I just wanted to thank you. I didn't mean to interrupt, but on the other hand, I want to tell you I think this is really important. Thank you.
Well, thank you so much for your comments, and we'll try to prove you right. If you just look at two case figures here, we know that not all patients are going to get AFib. First example on the bottom, you have a patient that has the only risk factors may be hypertension. They go through CBP run. Obviously, there'll be a little bit of inflammation, but for some reason, there's not enough for them to have AFib. In another patient, and that I would say is most of our patients nowadays, they have multiple risk factors, diabetes, hypertension, mitral regurg, and they go through the same CBP run, maybe longer, and inflammation occurs, and post-op day 2 or 3, they do develop it. So it is something that is triggered individually depending on the susceptibility. Now, this is a picture that's interesting. You can see here on the left side that there is a collection of blood. There is a chest tube squeezed to the left that is definitely not a standard chest tube, definitely not doing its job. And you can actually correlate the amount of blood that is retained in the pericardium with the amount of oxidative stress within the pericardial cavity. This is work from Melby in St. Louis, who actually documented that if you look at post-op myoglobin or in post-op CK-MB troponins, they're elevated in patients that do have retained blood. And this is by comparing the level of these enzymes or these compounds in the pericardial fluid versus the plasma. So how does it work? Chest tube clogging leads to retained blood, and the retained blood will undergo hemolysis. There's free hemoglobin that will be released, and this will oxidize and attract neutrophils and produce radical oxygen species. This will cause lipid peroxidation, and this may cause atrial damage or irritation, which may trigger post-op AFib. And this is pretty well demonstrated, and this is why less retained blood most likely equals less post-op AFib. In Montreal, at the Montreal Heart in 2014, we did a study which the design was pretty easy. We asked the hospital, we're in a single-payer system, how many can we buy? So we actually were allowed to buy 150, and we had 10 chest tubes as a bonus if we did. So we started out with 160. One surgeon didn't get the program too well, so we had 158 patients in a row that were done. Once we were done, money out, we went back to our standard drainage, and then we studied 186 standard drainage patients, and 44 of them were excluded, obviously, because they had a history of atrial fibrillation. So we propensity matched them, and you can see that even though we did not have a statistically significant decrease in RBS, that the decrease in post-op AFib was spectacular, with a relative risk reduction of 44%, with an odds ratio of 0.46, and this translated into a one-day reduction in length of stay. So our baseline went from 36% to 20%. You want this here now?
Yeah.
I'll save it for the end.
Yeah.
So, considering we did not have a significant effect on RBS and we had a spectacular effect on post-op AFib, we decided to put together a prospective randomized trial that's led by one of my associates, Philippe Demers, who does a lot of valvular surgery and aortic stuff, and we put together this study, which is ongoing. Basically, our plan is to enroll consecutive patients, and basically the test arm is one pleural flow in the anterior mediastinum with other standard chest tubes in the pleura, etc., versus the control group, which is standard chest tubes at the discretion of the surgeon. This will be analyzed as an intent to treat, and we started with a baseline of about 25%. As I said, it's probably more around 30% depending on the mix of cases. So we calculated to get an 80% power to detect a significant difference. We needed 508 patients in each group, and we do plan an interim analysis after 300 cases, which is coming up. So basically, the inclusion criteria were any patients that were undergoing CABG, valve surgery, a combination of both. We excluded patients that were undergoing deep hypothermic circulatory arrest, and the patients had to be in sinus rhythm for the last 30 days before the index surgery. That's a given. In the exclusion criteria, we excluded, again, circ arrest and VADS, transplant, endocarditis, and different conditions. So the primary performance endpoint, this is a matter of debate, was the rate of any new onset post-op AFib as defined by a period of 60 minutes consecutive that was objectified by telemetry or EKG at any time between the index surgery and discharge. And this is based on the AFFIRM trial, and also this was the definition that was used in the Cardiothoracic Surgery Network paper on rate versus rhythm control that Mark Gilnoff and Associates published in the New England a little while back. So to date, we've enrolled 200, I think as of 2 days ago, 253 patients, so we're close to the halfway mark. And we're looking forward to the interim analysis to see the effect we have. And actually, what we're also doing sub-studies within this, especially looking at laboratory and pericardial fluid difference between the cases that did get ACT versus standard drainage, trying to repeat in collaboration with Dr. Melby's group some of their findings, and also looking at clinical investigations, mainly imaging, to see how much fluid or clots are retained in a post-op patient, either undergoing standard drainage versus the active clearance technology. And I'll go back to this. So if you look at the level of evidence, usually right now, if you think that we have two retrospective studies that are non-conflicting, this is the Nuremberg data and the Montreal data that show a reduction in post-op AFib. And if you consider that the level of risk is basically nil, considering all patients will need a chest tube and the benefits may be great, I think right now this device is class 1, level B evidence, and we believe that with the further studies, we can bring it up to class 1, level A status. Thank you very much for your attention, and I'll answer any questions. Thank you.